All right, so let's talk about pneumonia. This is a pretty high yield topic. I can't imagine you won't get at least a question or two about this on the PANCE. Before we get started, I just wanted to thank everybody for the comments, the likes, the subscriptions. And if I could ask one favor, if you haven't subscribed to the page yet and you're watching this, you're liking the content, please subscribe. It's really the only way I can kind of get the word out about the channel. So if you subscribe, I would really appreciate that. So thank you so much. Let's go ahead and get started with pneumonia. I'm sure most of us are somewhat familiar with this topic, at least know some of the basics. It's pathogenic infection of the lungs with consolidation or interstitial lung infiltrates. Clinically, pneumonia is pretty simple. It's really you have a patient with a fever, a cough, and consolidation seen on chest x-ray. Boom, you have your diagnosis of pneumonia. It's really not that complicated. What makes it tricky, at least for exams, is all the different organisms that we'll go over, the different presentations based on the organisms, and just a lot of the different details, hospital versus community acquired. So let's go over those basics now, try to keep it to the stuff you really need to know for the exam. So first, we'll go over types. There's community versus hospital acquired, and this is an important distinction to make because it's going to guide your empiric treatment option, because the organisms you're going to acquire walking around at your local grocery store are obviously going to be much different than the ones that you're going to see in the hospital. So you need to know where they acquired pneumonia from. So starting with community acquired pneumonia, simply this is just pneumonia that's acquired outside of the hospital setting, or if they develop pneumonia under 48 hours of hospital admission, it's still considered community acquired. And then we have hospital acquired pneumonia. Hospital acquired pneumonia is just going to be pneumonia acquired 48 or more hours after hospital admission. The organisms that we're looking out for in this case are going to be Pseudomonas and MRSA. Those are the most common organisms you'll see in hospital acquired pneumonia. So really, community, this is acquired outside of the hospital setting. Hospital acquired, just remember, they've been in the hospital for 48 or more hours. So the assumption is it's a bug they acquired from the hospital, and we would treat them differently. There's also something known as ventilator-associated pneumonia. This is just pneumonia acquired 48 or more hours after endotracheal intubation. That's another one. Not very important, but just so you know, it is something, another type. Now, when we go into the organisms, seen pneumonia, they're important. There's a good amount you need to know about them, from the way the patient presents with certain types of organisms versus others, the treatment options. It's an important component of pneumonia. It's something you just have to be familiar with for your boards, but don't go crazy. I'm going to kind of break it down into just one or two things that you need to know about each one. So the first thing that I want to go over first is going to be your atypical versus your typical organisms that we see in community-acquired pneumonia. So let's start with our typical organisms in community-acquired pneumonia. You can see that one I put in red there, strep pneumo. That's the one you really have to know. It's the most common bacterial pathogen overall. Luckily in the US here, it's actually decreasing because of the vaccination, the pneumococcal vaccination, which targets strep pneumo, but it's still the most common bacterial cause of community-acquired pneumonia. So you have to know that one for sure. Some of the other ones that you may see are H. influenza, M. catarrhalis, Staph aureus, and Klebsiella. So these are your typical organisms, and they're going to have the classic signs and clinical presentations. You may have fever, you may have productive cough, purulent sputum, pleuritic chest pain, something known as rigors. If you're not familiar with that, it's not just chills. It's really like this full-on violent shaking, and it's very common to see in a patient with bacterial infections, especially with pneumonia. So that's something that you may see in a clinical vignette for the presentation. So these are your typical organisms, and this is your typical presentation. Now let's move on to our atypical organisms and which one those are. So this one, you can see I have Mycoplasma pneumonia in red rather than strep pneumo, because this is the most common one you'll see in atypical, and it's the one you're always going to see in a vignette. They like to always talk about Mycoplasma. So be really familiar with Mycoplasma pneumoniae. The other ones also are Legionella, Chlamydiophila pneumoniae, viruses, of course, too. Influenza A, B, adenovirus can all be atypical organisms that you'll see in pneumonia. So what's atypical about these organisms? Why are they called atypical organisms and not typical organisms? Well, there's a few different reasons. One is the presentation. So patients with atypical organisms are normally going to have a more indolent or less severe course. You may have heard of walking pneumonia. Well, that's with your atypical organisms. That's walking pneumonia. They're generally going to have less severe symptoms, maybe a slower onset. A lot of times they don't even know they have pneumonia. They just have a little sore throat and earache. They happen to have maybe a mild cough. You do a chest x-ray and you see this infiltrate. So The presentation, generally, nothing's 100% medicine, but generally less severe with your atypicals. Second reason why they're called atypicals is because of these unique extrapulmonary manifestations that you don't commonly see in your typical organisms. These patients may have diarrhea, like with Legionella. They may have otalgia, like we see with Mycoplasma. Extrapulmonary manifestations that you're not going to commonly see with your typicals. And then the third reason, probably the one that's not so important for a vignette, but just for the sake of your own knowledge, is these atypicals have resistance to beta-lactam antibiotics we don't see in the typicals, and they cannot be visualized on gram stain. So these are all things that make them unique or atypical, and that's why they're under the atypical organisms. So that's your atypical versus typical. Now let's break down the important organisms and kind of discuss what you need to know about each one. Just so you know, as I go over these, I'm going to go over some of the things you'll see in each, but nothing's really exclusive here. It's not like if I say chronic alcoholism is seen in Klebsiella, it doesn't mean it can't be seen in strep pneumo. It's more common to see those in this type of organism. So nothing's 100% specific, but I'm going to go over the things you'll likely see on an exam and the things that you're just more commonly going to see with each organism. And I'm really boiling it down to just the need to know stuff, because you could drive yourself crazy knowing every unique detail. So let's start with the big one. The one I told you need to know, strep pneumo. So one you already know because I went over it. It's the most common cause of community-acquired pneumonia. And then the second thing that's unique that you'll probably see in a vignette description is they can sometimes have this blood-tinged, or it's sometimes described as rusty sputum. So that's something you may see in a vignette that'll kind of clue you in that it's a strep pneumo infection. So I really think you should waste your time about knowing with strep pneumo. Next one, Haemophilus influenza. The one thing you need to know about Haemophilus influenza is COPD. That's what you'll likely hear about in a vignette when it comes to H flu. Other underlying pulmonary disorders as well, asthma, bronchiectasis, but the one you're always going to hear about is COPD. The way that I used to remember this, it's kind of a weird way, but hopefully it'll work for you. And again, I have no opinion about police officers. This is just a mnemonic. I'm not expressing an opinion one way or another. But I'm sure we've all heard of cops being called pigs. I'm sure you've heard that before. Again, I'm not expressing an opinion, just giving you a mnemonic here to remember this. So Haemophilus influenza kind of sounds like Haemophilus influenza, ham, pig, COPD. Whoops, that went away there. I can't go back to it, but COPD, cop, COPD spells cop. So you think of Haemophilus influenza, you think of a pig, then you think of cops being called pigs, and then the word cop is in COPD. So that might help you. It helped me. It was just a weird way to remember it, so hopefully that'll kind of stick it in your head, that visual there. Next one is Klebsiella pneumoniae. Klebsiella, the way that there's something unique about Klebsiella, and it all starts with C's. So when I used to think about Klebsiella, I'd remember that Klebsiella is not spelled with a K in my mnemonic. It's spelled with a C, because that helps me remember some of the things that you need to know about it. The first thing is chronic alcoholism. You're always going to see in a vignette, or most of the time, they're going to give you a patient who's an alcoholic that presents with currant jelly sputum, and then you know right away they're talking about Klebsiella. So that's the first thing, chronic alcoholism. It can also be seen in some chronic illnesses like hospitalized patients with impaired host defenses, diabetes, but you'll always see in a vignette it's going to be chronic alcoholism. So that's your first C. Second C, like I said before, currant jelly sputum. This is due to the increased inflammation and necrosis that can be seen in these patients with Klebsiella infection, and it leads to this thick blood-tinged sputum that's referred to as currant jelly sputum. So that's your second C. Your third C is cavitary lesions. So kind of plus or minus, some sources will say this is found in about 30 to 50% of patients with Klebsiella that have these cavitary lesions on imaging. Take it with a grain of salt. The data is kind of maybe outdated. It's not as prevalent as once thought, but it's one of those things that you'll probably see on a vignette, and you should know for Klebsiella pneumoniae. So remember, Klebsiella is not spelled with a K, it's spelled with a C, and that reminds you of your chronic alcoholism, currant jelly sputum, and cavitary lesions. Those are your 3 C's for Klebsiella. Moving on to Staph aureus. So Staph aureus, the only thing I want you to remember about this is post-flu. That's it. Post-viral infection, really flu, though, is the way you always hear about it. So Staph aureus pneumonia, it's community acquired. That's usually seen in patients who are recovering from influenza. So post-influenza pneumonia is how you should remember it. Staph aureus, just remember post-flu, and that's it. Mycoplasma. Again, remember this is one of your more important ones because it's one of your most common causes of your atypicals or your walking pneumonias. So the main thing about this is that these patients are going to have mild symptoms. Remember, that's what I went over with a lot of your atypical. So be thinking of that first. You're also likely going to see in a vignette a young and healthy patient that's living in close proximity. Because mycoplasma pneumonia is spread via respiratory droplets, you'll see this infection arise among individuals living in close quarters. So family members living in the same household, kids going in school together, healthcare facilities. The one you'll always seem to hear about in a vignette, the way I always remember it presented, was somebody that was in a military barrack. So they'll say somebody that was in military barracks and now presenting with this ear pain, cough, blah, 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 and you should be thinking mycoplasma. So remember, young and healthy patients living in close proximity. And then your extrapulmonary symptoms, of course, which I went over. This is something that you'll likely see in patients with mycoplasma pneumonia. So cough, sore throat, rhinorrhea, coryza, otalgia, your ear pain. It's common to have upper respiratory symptoms with mycoplasma infection. Another thing that I want to go over before I move on to cold autoimmune hemolytic anemia is something that you might hear about that's not really true anymore. So bullous meningitis is something that I know I was taught in school. It's something that for many years was believed that it was associated with mycoplasma. It's these fluid-filled blisters on the TM, the tympanic membrane. But new studies are saying that there's really no association between the two. So if you see it, sometimes the PANCE is like outdated by 2 to 3 years, so it's possible you might see it on there. So I'm saying it just in case you do. But new studies are kind of showing there's really not any association between mycoplasma and bullous meningitis. Just an FYI there. Okay, so the last thing, cold autoimmune hemolytic anemia. It's possible to develop this with a mycoplasma infection. I'm not going to go too deep into this, and just know if you see a vignette that describes cold autoimmune hemolytic anemia, it can be seen with mycoplasma. It's just a type of hemolysis where the antibodies attack blood group antigens that are only in temperatures that are lower than normal body temp, so cold agglutinins. Don't worry too much about that, but if you see that, know it is associated with mycoplasma. So that is your mycoplasma pneumonia, a little bit more that you need to know about that one. And then we have finally your Legionella. So Legionella, the main thing you should know about this is if you see a patient presenting with cough and diarrhea, combined in a vignette, right away you should be thinking of Legionella. Real life, of course, there's a million other possible reasons a patient could have both of these, but in a vignette, you should be thinking of Legionella because you can have your GI symptoms combined with the upper respiratory or the lower respiratory, the cough and everything else in these patients, and that's really key to making that diagnosis. Then the other thing is if they mention anything with an outbreak with contaminated water sources. So they may mention a hot tub in the vignette, a humidifier, an AC system, something that can lead to the transmission via inhalation of this aerosolized mist from water sources. That's your key in a vignette. They're going to mention something, some kind of water source, and that a bunch of people got sick. It can also be transmitted through soil too, just so you know, but you're not going to hear about that in a vignette. Just not common. So the way that it's likely going to be tested on is inhalation through a water source. Remember that. And then a couple lab findings, hyponatremia, and then elevated hepatic transaminases, your liver enzymes like AST, ALT. Not specific findings, but if you see these lab findings combined with the patient with some of those other symptoms like diarrhea, cough, proper history, be thinking of Legionella. So remember those lab findings as well. All right, so those are, I know it's a lot, but those are your organisms and just a few things that I feel like you should really know about each to kind of help you make the diagnosis on a vignette. Next thing that I'm going to go over is diagnosis and some of the tests you'll use. I'm going to make this brief because a pneumonia diagnosis is made using a spectrum of clinical and diagnostic findings. There's really no best test to diagnose, and the diagnostic tests are pretty low yield for the exam. So I'm just going to kind of breeze through these so we have a general idea. So chest x-ray, if you have a patient that has your typical organisms, generally it'll be a lobar pneumonia. Again, none of this is 100%, and then the other thing that you'll hear described is if it's an atypical organism, a lot of times it's more of a hazy or patchy infiltrate. It's not as well formed of an infiltrate as we'll see with our typical organisms. A lot of times it's kind of this like hazy or patchy infiltrate on atypicals. That's something that's another reason why it's an atypical presentation is their findings on imaging. It's more hazy. So that's just something on chest x-ray you should be aware of. Your CBC, of course, you may see leukocytosis like in any infection. Serum electrolytes and your BUN should be obtained as well. Your BUN will be important for something known as the severity scoring we'll go over later, CURB 65. And then you may obtain blood culture, sputum, gram stains, and cultures, but this is really reserved for patients with moderate and severe pneumonia. You're not going to be getting a sputum culture routinely in a patient you're treating in the outpatient setting. It's more of a patient that is inpatient, maybe an ICU patient, because it's hard to get these cultures not getting contaminated by the oral flora and everything else. So again, definitely not a routine thing to get, but it is something that you can obtain in labs to get a diagnosis about the specific organism. And then finally, PCR testing. This is something that you'll use in your Legionella, and Mycoplasma really is the place for these types of diagnostic tests. So those are the diagnostic tests. The next thing that I'm going to go over is a couple different severity index tools, calculators. Really, there's only one that I'm going to focus on. So these are calculators used in patients with pneumonia to determine how severe the infection is and how they need to be handled, whether as an inpatient, outpatient. So the one you're going to be tested on is CURB 65 because it's easy to memorize. There's really only a few things you need to know about it, so they can test you on it. The more accurate test, though, the one you'll probably see in clinical settings and the ER and everything, is known as your Pneumonia Severity Index, or PCI. There's just way too much to know about this test. There's over like 20 components of it. So really, it's something that you'll do in the field when you have your MD Calc app or you're going to a website, you're in the ER. But on an exam, they can't ask you about it. There's just too many components and it would be unfair. But the one they will ask you about is CURB 65, and I did get a question about this. So let's focus on that and go over the components of CURB 65. So CURB 65 stands for confusion, altered mental status, urea, or your BUN, which is over 7 millimoles or over 19 milligrams, over 19 mgs, your respiratory rate, 30 or more breaths per minute, blood pressure, either your systolic under 90 or your diastolic less than or equal to 60, and then age 65 years or older. Now, what do all these things mean? What do the score mean? So you calculate all of these. If they get 1 point, you're kind of in between. 0 points, you're going to treat them as an outpatient, so you don't have to worry about that. As soon as you hit 2 points, you need to be considering inpatient treatment. If you hit 3, you should be considering ICU. So in between 0 and 1, it's kind of like, if you look at up to date kind of says as soon as you hit 1 to 2, you should be considering inpatient, but most scores, if you go to MD Calc, they say not until you really hit 2 points should you be considering inpatient. So you'll see a variation in the in between 0 to 2, but what you should remember for the exam, 0 points outpatient, 2 points inpatient, and then 3 or more points ICU should be considered. That's your CURB 65. So you just calculate all of these things, and then you decide how you're going to treat them, if you're going to admit them, if you're going to send them home on outpatient therapy. So this is the score you'll use for that. There's a simplified one that you can use like in an outpatient setting if they're in the doctor's office without the urea, without the BUN, and you can just use CRB 65 and you can go based upon that. But these are just some things that you're going to use like in triage and simplified ways of kind of making an assumption about how these patients are going to be treated. So that's CURB 65, easy one to just remember, and might get you an extra question on the exam if you can remember that. Nothing to go crazy over. So next, treatment. So hopefully you catch your breath here, you're feeling okay, because treatment's a little bit intense. So before I start with the meds, I just want to add the disclaimer. There's a good amount to know. It's a little bit confusing. I boiled it down as best I could, but just don't kill yourself with this. Know the basics, and just don't waste your time on anything beyond that. There's too many other things that are more valuable for you to know for the exam. So let's get started with the most mild patient you're going to encounter. This is your community-acquired pneumonia in an outpatient setting. So you're going to treat these patients in the office, send them home. What are you going to treat these patients with? So you have a few different options. You have your macrolides, your azithromycin, your clarithromycin. Azithromycin is more commonly used. Amoxicillin is another one. Doxycycline, and then finally we have our fluoroquinolones. So fluoroquinolones, just know that you can use respiratory fluoroquinolones like your moxifloxacin, levofloxacin, gemfloxacin is another one, but because of the adverse effect profile, the potential of promoting fluoroquinolone resistance, this class is only reserved for patients with either contraindications to the preferred regimen or if they have comorbidities. If you see a patient being treated by your preceptor, whoever, with just Levaquin right off the bat, it's just not in the It's just not great practice unless they have some specific reason, some comorbidity or something that they're using it. Otherwise, you want to stick with your other three medications up here. These are the ones you generally want to stick to. This is like a last line type of thing. So the way that I used to remember these classes, and again, these can be used as monotherapy, any one of these, or if you look at up to date is more starting to suggest an amoxicillin combined with either a doxy or a macrolide. So the thought there, if you look at different sources, you're going to get different answers. But a lot of sources say monotherapy with any of these for outpatient. And then up to date is starting to suggest that the best course would be an amoxicillin to kind of really target your strep pneumo, which the beta-lactam is really good at that. And then combining a doxy or macrolide with that to get your atypicals. Don't worry about that too much, though. If you see an exam question and you see like a Z-Pak on there, azithromycin, that's probably going to be your answer. I wouldn't worry so much about the combination. As of this point, we're kind of still at the point where any of these are monotherapy. They can be combined, but don't stress yourself out about that. All right. So that's your treatment options for outpatient. How do I remember that? Well, the way I remember that is you're effing mad, you got pneumonia. You're effing mad, you got pneumonia. So effing mad stands for fluoroquinolones, macrolides, amoxicillin, and doxycycline. So that's your community-acquired outpatient. You're effing mad. F stands for fluoroquinolones, M stands for macrolides, so your zithro, your chlorithro, and then A stands for amoxicillin, and then D stands for doxycycline. So generally just remember any one of these monotherapy can be used with that little FYI I told you about up to date. That's starting to list a combo of this with one of these. So effing mad, fluoroquinolones, macrolides, amoxicillin, doxy. Next, we're starting to get a little bit more severe here. So now we have a community-acquired pneumonia, but we're deciding that this patient needs to be treated in an inpatient setting. So now we have our fluoroquinolones, of course, again, with the same caveats that I discussed above. But you also have another option here. So what you're going to have to do if you're not using a fluoroquinolone, you're going to combine a beta-lactam, so that's ceftriaxone. Normally the one you'll hear about is ceftriaxone, ampicillin sulbactam, which is Unison, ceftaroline, ertapenem, any one of those from the beta-lactam class. Combined, you can't use it by yourself. It has to be combined with either a zithro or clarithromycin. Again, azithromycin is more commonly used, or a doxycycline. So community-acquired inpatient, fluoroquinolone all by itself. You can see why this is so tempting because it's just monotherapy. You give them one pill a day of Levaquin and you're all set. But if you do it the right way, you're going to have to combine two different medications, which obviously leads to non-compliance a lot of times, or it's harder for a patient to take two different classes. But the other option is beta-lactam, one of these, ceftriaxone, ampicillin, sulbactam, combined, can't be by itself, with either macrolide, azithromycin, or clarithromycin, or doxy. So that I remember this, now we're inpatient, things are getting a little bit more scary. And before you were mad you got pneumonia, but now you're being treated as an inpatient, you realize things are starting to get effing bad. You're no longer mad, you're starting to get worried and realize things are getting effing bad. So things are starting to get effing bad, you're treating community-acquired pneumonia in an inpatient setting. So fluoroquinolones by itself, remember, monotherapy. BAD stands for, remember, beta-lactam, ceftriaxone, any one of those, combined with either azithromycin, I listed azithromycin because it makes the mnemonic work, plus it's the more commonly used macrolide, or doxycycline. So fluoroquinolone by itself or beta-lactam combined with either azithro or doxycycline. That's your CAP inpatient treatment. All right, last one. Finally, we have pneumonia treatment for a hospital-acquired patient. So now we have to worry about our hospital bugs. We're worrying about Pseudomonas, we're worrying about MRSA. So if we have to cover a patient with Pseudomonas, what we're going to use is going to be your anti-pseudomonal beta-lactam. So that's piptazo, your piperacillin tazobactam, your cefepime, your ceftazidime, any one of those you can use to cover Pseudomonas. So that's pretty much across the board. You're going to use a Pseudomonas antibiotic empirically. Remember, these are all for empiric treatment. We don't have a culture back to guide us. We have to just start shooting right off the bat and assume, the coverage. If they mention there's a MRSA risk, a risk for MRSA, what you're going to use is either linezolid or Vanco. Now, this is about as far as I think you should go for hospital acquired. Remember, you need to cover your Pseudomonas, so anti-pseudomonal beta-lactams, piptazo, cefepime, ceftazidime. And if they mention MRSA, then you're going to cover with linezolid and vancomycin. I'm going to add a little FYI, but I don't want you to go further and memorize this, but sometimes you'll see that they say, do you need an anti-pseudomonal fluoroquinolone or aminoglycoside? You don't in every patient. You're only going to use this in a patient that has risk factors for gram-negative bacilli, like a patient with structural lung disease, bronchiectasis, cystic fibrosis, There's a gram stain that showed positive, a bunch of different factors, but this isn't used in everybody, and I wouldn't, go further than that. All I would remember for hospital acquired, covering Pseudomonas always, one of these, and then MRSA if they mention it, one of these. And that's really it. Don't waste your time going any further than that. So that's your treatment. It's a little complicated, but I kind of boiled it down to the need to know stuff. Of course, there's so much more than this. There's so many different bugs, or does the patient have this comorbidity? Do they have this? And you can go so much further, but you just can't do that. You have too much to memorize otherwise. So let's leave it at that for treatment. I touch on a few miscellaneous topics and then we'll wrap it up. So miscellaneous, first one that I want to go over, aspiration pneumonia. Really only a few things that I want to go over with this. So first, you're going to commonly see this in chronically ill patients. So patients with reduced consciousness, like patients that are on sedative, antipsychotics, alcohol, elderly patients with altered mental status, patients who are having a seizure, stroke. Really anybody that has a risk for aspiration, they can aspirate their stomach contents into their lungs, which leads to this infection, this aspiration pneumonia. So those are the patients you're going to look out for. A lot of times you'll see a patient with alcohol use, chronic alcohol use, whatever it is, that vomited, passed out, and now has aspiration pneumonia. So first thing you need to know, most commonly caused by your anaerobes. Anaerobes are really important because that's what you're going to treat them for when you treat with antibiotics. So remember anaerobes. Now here comes probably the most important thing, because this is going to give you your vignette key, and that's a foul-smelling sputum. You're not really going to see this many other times, but the reason you have foul-smelling sputum, or this sputum that has this putrid odor, this finding is considered diagnostic for an anaerobic infection, like we see in aspiration pneumonia. Like I said, this is the most common organism. So you see a vignette that says foul-smelling sputum, right away think aspiration pneumonia. How are we going to treat them? Well, remember, we're treating an anaerobic infection, so we're going to treat either with ampicillin sulbactam, that's IV IM, so normally that's for your inpatients, and then amoxicillin clavulanate, which is augmentin, more for outpatient settings because it can be given PO. Remember, like I said, we're treating an anaerobic infection, so we need that combination of a penicillin plus a beta-lactamase inhibitor, like your clavulanate or your sulbactam, and that's why we're using those classes. So remember, aspiration pneumonia, most common anaerobe, you're going to see it in a chronically ill patient with reduced consciousness, foul-smelling sputum, and then treatment with ampicillin sulbactam or amoxicillin clavulanate. That's all you need to know for aspiration pneumonia. Next two, or the last two that I'm going to go over, they're kind of also infectious disease, a little bit of a crossover here, but they can easily be lumped into a clinical medicine exam for pulmonology because they are pneumonia causes. So I'm just going to go over a couple basics and some mnemonics for you to remember these because I think they may come up. So first one is histoplasmosis. So this is a fungal infection. It's caused by breathing in spores of a fungus that's often found in bird and bat droppings that can lead to pneumonia. What I want you to know for histoplasmosis, I just want you to remember the word bird, because remember it's caused by bird and bat droppings, so just remember the word bird. What does bird stand for? So bird stands for bird and bat droppings, that's your B, so that one's easy. I stands for itraconazole, because this is going to be your first line treatment for mild to moderate disease, like in an outpatient setting. You can use amphotericin B, but this is only for your really severe cases. If you've gone over infectious disease already, I'm sure you've heard about amphotericin and heard how horrible of a drug it is and how many side effects and problems. So really it's just reserved for your severe patients. There's a reason they call it amphotericin. It's just a really strong med. So otherwise, itraconazole, mild or moderate disease. Your R stands for river valley. This is going to be because it's common in the Mississippi and Ohio river valleys, because the soil in this area is rich in bird and bat droppings. So that's what you need to know for this as well, because that'll likely be in the vignette. You also may hear about this in patients who do, I think it's called spelunking, is cave, like cave exploring in caves. But anybody who's in a cave for whatever reason because of the bat droppings again. But really the main thing is that Mississippi and Ohio river valleys. And then finally, the D stands for defining illness for AIDS, because this is an AIDS defining illness. If you're not familiar with what that is, certain diseases, if a person has HIV and gets one of these diseases, like histoplasmosis, they're now considered to have AIDS, and that's why they're called AIDS defining illnesses. They're diseases you're not going to see in a healthy, immunocompetent individual. So histoplasmosis is one of those AIDS defining illnesses, and usually occurs when the CD4 count is less than or equal to 150. So remember, BIRD stands for bird or bat droppings, itraconazole, that's your first line for mild moderate disease. River Valley, your Mississippi, Ohio river valley is where this is common. and the defining illness for AIDS. That's all you need to know about that. And then our last topic is going to be your PCP, your pneumocystis pneumonia. So this is a yeast-like fungal infection, which is most commonly caused by something known as Pneumocystis jirovecii, or jirovecii, however you want to pronounce it, that leads to pneumonia infection. There's 4 things I think you should know about this, and then leave it at that. So the first thing, it's another AIDS-defining illness. This time you're looking at a CD4 count less than or equal to 200. On labs, this one's pretty important because this is the one I saw in a vignette. You may see increased LDH on labs. So that's your serum lactate dehydrogenase. LDH levels are actually elevated in about 90% of patients with PCP who have HIV. So that's another important thing to look for on labs. On chest x-ray, you may see something known as a bilateral interstitial infiltrates on chest x-ray. The way it presents, it actually looks like a bat wing pattern, just the way the infiltrates kind of present. So that's just something you may see. And then finally, probably the most important thing is that treatment and prophylaxis. Prophylaxis, again, once their CD4 count reaches 200 or less, you're going to prophylax. And treat, of course, active disease is going to be with Bactrim. Bactrim is also, of course, the generic is trimethoprim sulfamethoxazole. The way that I used to remember that, because this is probably the most important thing, is that you need to know that Bactrim is how you treat these patients, is I remember this beautiful picture here. Pneumocystis pneumonia, known as PCP. Stands for your posterior is coarse and prickly. PCP, your posterior is coarse and prickly. His posterior is coarse and prickly. You need your back trimmed. Back trim, you need your back trim. So PCP, first line treatment prophylaxis with back trim. So PCP, posterior coarse and prickly, you need your back trim. That's how I used to remember it. I never forgot that, even though I've never treated PCP, and you probably won't either, but you'll probably get a question on it though still anyway. So you should know that. All right, that is pneumonia. Let's do 5 quick questions. First question, what is the most common organism seen in community-acquired pneumonia? Most common organism is going to be strep pneumo. Second, homeless patient presents to the ER with a productive cough, foul-smelling sputum, and admits to blacking out last night due to excessive alcohol use. Which antibiotic should be considered in this patient for the likely diagnosis? So you got your key there, your foul-smelling sputum. Remember, this is a very classic vignette for a patient with aspiration pneumonia, so you're going to use your amoxicillin clavulanate or your ampicillin sulbactam. Remember, we're covering our anaerobes there. Question 3, what organism should be considered when prescribing empiric antibiotic treatment in a patient with hospital-acquired pneumonia? What bugs are we covering in hospital-acquired pneumonia empiric treatment? That's going to be Pseudomonas and MRSA. All right, question 4, 17-year-old male presents at the office today with pharyngitis, non-productive cough, and an earache. On chest x-ray, a patchy infiltrate is visualized. What is the likely organism causing this patient's symptoms? Hopefully you can remember that. It's Mycoplasma pneumonia. Remember, your most common cause of your walking pneumonia, your most common atypical organism. Remember, this patient has very atypical symptoms for pneumonia: pharyngitis, non-productive cough, otalgia, earache. So remember all those extrapulmonary symptoms that you don't normally see in typical. And then on chest x-ray, we didn't say like a well-defined lobar infiltrate, we said a patchy infiltrate. So it's another key to your atypical organism. And then remember, he's a young guy and less severe symptoms, so mycoplasma should definitely be what you were thinking. Last question, question 5. What antibiotics are commonly used in the treatment of community-acquired pneumonia in an outpatient setting? So CAP in an outpatient setting, this is your least severe. Remember, you got pneumonia and you are effing mad. So fluoroquinolones with that little asterisk, because you remember this is really only going to be used in comorbidities, contraindications for the preferred therapy, and then you can use any one of these. This is why you're mad, you're effing mad. Macrolides, amoxicillin, doxycycline. Remember, monotherapy on any one of these, potentially combined amoxicillin with a macrolide or doxy, depending on the source you're looking at. All right, so those are your questions for pneumonia, and that is pneumonia in a nutshell. So hopefully that was helpful. Please, like I said, if you haven't subscribed yet, I would really appreciate it if you did. And please let me know in the comments if this is helping you. Good luck on your PANCE, your PANRE, your EORs, and good luck in PA school. And thank you for listening to the video.